wanted to start off by welcoming everyone to the third edition of Coffee and Collaboration, which is presented in collaboration with the Center of Excellence in Mental Health and the CEYMH. For those of you who don't know me, my name is Kelsey, and I'm one of the clinical coordinators at the Center of Excellence. And I basically manage partnerships with clinicians throughout. So as a reminder, we started this event back in September of 2025, and the goal of it being a bi-monthly knowledge sharing event to foster better collaboration, communication, and discussions across research teams and clinicians here at the Douglas. And the goal of this event is really to strengthen collaboration between research teams and clinicians, improve knowledge translation, foster innovation, enhance communication, and monitor impact over time. So without further ado, it's my pleasure to welcome three speakers here today. The first being Dr. Mandy Steiman, who's a clinical psychologist here at the Douglas, and she'll be presenting on Pediatric Diagnostic Pathway of ASD. Then we have Elizabeth Guevera, who's an OT and clinical coordinator at Aire Ouverte, as well as Jessica Mitsou, who's an occupational therapist and project manager from Aire Ouverte. And they'll be presenting on the services offered at Aire Ouverte, as well as their research collaborations. And then finally, we have Allison MacNeil, who's a clinician and researcher here at the Douglas in the J. Shaw Lab, and she'll be presenting on the Clinic for At-Risk Youth here at Douglas.
Hello, my name is Mandy Steiman, and I'm a clinical psychologist. I work at the Autism Spectrum Disorder Evaluation Clinic at the Douglas, and I will be presenting a project that we did recently called the Pediatric Diagnostic Pathway. So my goal today is to present the development and implementation of the Pediatric Diagnostic Pathway, which was and continues to be a project to increase capacity for autism diagnostic evaluation. The project was informed by research and best practices. It's an interdisciplinary collaboration between the DI-TSA-DP program, which is at 8000 Notre Dame and evaluates neurodevelopmental disorders, along with me at the Douglas, working at the autism clinic and with pediatricians at LaSalle Hospital. So the project aimed to address services at the Équipe d'évaluation des TND, which is an evaluation clinic for ages 0 to 12 years, which assesses autism and other neurodevelopmental disorders like intellectual disability. The project was inspired by a large waitlist for ASD assessment, autism spectrum disorder assessment. And although the staff is wonderful, it was limited in terms of how many people are working there. So at the time of the conception of the project, there was a full-time coordinator, a full-time occupational therapist, a full-time speech and language pathologist, a full-time social worker, and then psychoeducators, two of them that were assigned to the team to work on this project for 1 day a week each, as well as a psychologist who was not participating much in the project. She was focused on other cases, but she continues also to be on the team for 2 days a week. So the staff actually has changed a little bit since the project started about a year and a half ago. Uh, but this was the staff that we were working with at the time. And at the time, there were hundreds of children on the wait list and a limited capacity for diagnosis because the diagnosis must be made by a doctor or a psychologist when you're thinking about autism spectrum disorder. But the psychologist that we had, it was only around for 2 days a week. And the purpose of the project was to try to find alternatives to using this psychologist time. So we thought about who else is available within the network to help. And there are pediatricians at LaSalle Hospital who were open to collaborate and could provide up to 1 day per month of uh, pediatrics time to help with diagnosing children for autism spectrum disorder. So I was brought into the project as a consulting psychologist to help with training and to help organize the services of this new clinic, as well as to help with this new project of how exactly do we increase our capacity with 1 day per month for some pediatricians, and the existing staff we had. That was the problem, and that we were aiming to solve. So the goal was to increase the diagnostic capacity with these resources. Diagnosis of autism has a lot of um, attention on it. And in 2019, the Canadian Pediatric Society gave position statements on autism spectrum disorder diagnosis, and these helped inform the project. One of the main messages of these series of papers, which you could find online, is that a one size all approach to autism assessment is likely inefficient, and different approaches can be taken based on the complexity of symptoms. So, for example, at the Douglas, we see in our clinic children and young adults with comorbidities already identified. So, already complex cases who are coming in. But there's other cases of autism, maybe younger children with more clear symptoms that would require a different approach. The papers, the position statements, identified one option being a pediatrician consulting with another healthcare provider to inform the diagnosis. However, in practice, this tends to be rare due to many practical concerns. Some of them being that it takes a lot of coordination and time and report writing and form filling to do an autism spectrum disorder assessment, and pediatricians have very limited time. So, how could we get them involved and use their diagnostic abilities, but also work alongside the other team members? Another piece that inspired this project was, of course, going back to the research and seeing what research says about the accuracy of pediatrician diagnoses. So, this was one of the papers I looked at that ended up informing our model in a pretty big way. So, this is a paper by Melanie Penner, who is a doctor in Ontario, who wrote this paper on comparing pediatrician assessment versus multidisciplinary assessment in terms of accuracy of ASD diagnosis. So they had about 17 pediatricians involved in their study, and over 100 children who were quite young. And this fits the profile of the children that are seen at the team where we did our pediatrician project. And what they found was that when the pediatrician was certain or very certain about the autism diagnosis after doing an evaluation with the child, their accuracy was quite good if you are using a multidisciplinary assessment with a bunch of standardized tools with many different professionals. Um, it was very similar to that in terms of accuracy, but the accuracy was best, like I said, when they were certain or very certain of the diagnosis. So if they did a certainty rating, as you could see on the bottom over here, there's pediatrician certainty ratings that go from 2 to 5, with 5 being the most certain. And if they had a certainty rating of 5, the pediatricians, their sensitivity, so their ability to detect ASD, was very good. So they had a high accuracy. Um, of course, the multidisciplinary team was more certain than a pediatrician in terms of what the diagnosis was for the child. But when the pediatrician was more certain, their ability to diagnose got better. Ruling out the diagnosis of autism tends to be more difficult because this tends to happen with children with maybe milder presentation. So this means maybe they're more verbal or they have fewer cognitive delays. And in those cases, the certainty rating will go down and the accuracy of pediatrician diagnosis as compared to multidisciplinary assessment as the good standard, it would go down. So, to put these pieces together to develop the project, and the goal that the team had was to create a highly structured and streamlined process for maximum efficiency and quality of the process for the team, for the families. So we decided to standardize training, forms, the process, report templates, etc. So try to make a package that all fit together that the team could use and could be used in the future to train future employees and trainees who would be involved in this project. The goal was also to effectively use pediatrician time, so and involve them in the diagnosis part. So, of course, uh, observing the symptoms and getting a sense of all the symptoms, but also giving the diagnosis they were needed for that part in particular. We wanted to make sure that the staff collaborated at all stages of the project development, and we wanted to make sure that the project was family centered so that families wouldn't have any less of a quality assessment because we were doing it this way as compared to the typical way, which involved a psychology assessment and more appointments. My job on this project was to help create these standardized forms and training procedures, and also to help lead this pilot and refine the procedure based on the team's feedback. What we ended up with was this procedure for our pediatric diagnostic trajectory. It started off, so we started off with children aged 1 to 4. We decided to focus on this age group because these kids aren't yet in school, so it's a less complex assessment than some of the other kids who are aged 5 to 12 at the clinic. And we included children who already, from the screening done through Agilto, through the file and documents that have already, been collected through our initial orientation call that the team does with the family to get some base information. There was a high suspicion of autism. So we're thinking that these are the kids with the more clear core symptoms of ASD who are likely to be the ones that pediatricians could be more certain about that they have the ASD diagnoses. So like I said, there's an orientation call that happens with the family. So that was then to ensure that this was a good family to include in this pediatrics trajectory. We would schedule the family. So looking over now to the yellow box, then the procedure involved a developmental history and clinical observation session. So this is one session of about an hour and a half with an occupational therapist and a psychoeducator, although this could be with any of the allied health staff as long as you have two. So one staff member is doing the developmental history, getting a history about the child's behavior from the primary caregiver or caregivers, and the other is taking the lead on the clinical observation of ASD symptoms of the child. This all happens in one room. They confer at the end of this appointment to give their own certainty rating of the presence of autism spectrum disorder out of 5, similar to the paper, and prepare the file for the diagnosing clinician. If these clinicians in this yellow box, if they are certain or very, very certain that the child has an ASD diagnosis, we continue along the pediatric pathway into these blue boxes. If they're feeling less certain, so maybe we screen the file for a high suspicion of autism, but it's not quite clear when you meet with the child. If it's a more complex case, they would leave the pediatric trajectory and enter a psychology pathway where the psychologist would take all the information gathered and complete the evaluation and make the diagnostic decision if there's ASD or not. If there was the higher certainty, though, like I said, they stay on the pediatric diagnostic trajectory. And there's a pediatrician meeting of about an hour to an hour and a half where there is a medical evaluation, additional clinical observation, this time by the pediatrician to ensure that they agree with the presence of ASD symptoms. And if they do, if the pediatrician has a high certainty rating, they will go ahead and diagnose ASD for the child and give feedback. One of these clinicians that initially saw the family is also present for continuity and to support the family. If the pediatrician is less sure, the case can go back to psychology. So far, that hasn't happened yet, but we have had a lot of cases, or I'd say a minority, a small amount, maybe, 1 out of 5 or less, between 1 out of 5 and 1 out of 10 cases that end up leaving over here to enter this pathway, with the vast majority continuing on to the pediatrician pathway. The update for this project is that we initially developed the project in March to July, so even just starting to talk about it. And then July to September, the project was piloted with an occupational therapist and consulting psychologist, me. And then after we created drafts of the forms and the processes, we were able to include the pediatricians and the psychoeducators in the pilot. And since January, we've been finalizing the procedures and continuing with training and continuing along uh, toward the future. We're just finishing that and bringing more staff into the project as the composition of the clinic changes, and I will be staying involved to provide ongoing consultation and skill development for the team members. What's amazing about this project is that we were able to triple, and that's conservative estimate. It's probably more like quadruple the ASD diagnostic capacity that was available when we first started, without actually even adding any additional staff, but just by reconfiguring how the staff worked and bringing in these pediatricians for 1 day a month. So that's something that the team is very proud of, and we're very excited about, because that could help diagnose many more children over the course of the year and reduce the wait list. One of the things that we should have been thinking about before, but ended up being just a very pleasant surprise, is just how much staff learned through sharing knowledge with each other in these meetings that we ended up having where we had multiple professionals there at the same time. We ended up learning from each other a lot. So non doctors learning from the doctors, and the doctors learning from us. The Tunes learning from psychologists, just back and forth. All of us learned a ton by doing this project, which improved our service delivery to the families. And we received a lot of positive feedback from families and staff. The families were very relieved that they were finally seen after waiting quite some time on the wait list. And they seemed to appreciate having fewer sessions and not having to come in as much. It's very difficult for families to attend meetings with small children, and it's very hard for the children as well. So the fact that we could do this all so efficiently by working with multiple professionals at once in one appointment served the families really, really well. And we've received lots of good response from everybody involved. So some takeaway messages are that Team collaboration obviously benefits staff and families. It was very helpful, I think, that having a clinical leader, so having me on the organization piece while everybody else did their job, helped keep the momentum a little bit. So I think, like, for future projects, instead of everybody sharing the responsibility to develop all the forms and the procedures, it's nice to have somebody who's kind of helping to organize that, so everybody's having input, but one person is organizing it. I think it helped us move along the project fast, all the way from just thinking about it to it working well in a year. That was quite quick to make a major change like this in how a clinic works. What was also helpful, I found, was keeping it very small during the initial project development. So, of course, we talked to all parties. We had meetings a little bit, but the main piloting was just with me and the occupational therapist, Caitlin Kerr, who was involved. And we, just kept getting kind of like feedback as we went. And then we later brought in the psychoeducators, which was great. As the pilot expanded, the team feedback on all aspects because everybody was involved on all aspects, saying what they liked, saying what they didn't like, helping to change the forms, etc. Really improved the process. Everybody's input was so helpful, and everybody was coming from different disciplines, which was fantastic. And that also helped with buy-in from all the professionals too. We were also very fortunate to have excellent managers who provided a lot of support for the project. And because it was something that everybody wanted and the managers were very supportive of, it just moved through really nicely. And there were a few barriers to implementing the project in the team. It was really a pleasant experience for everybody. So I just want to acknowledge my team members at the clinic, at the day TSA DP program, as well as the managers involved, here and there. It was just such a, wonderful group of people to work with and that I continue to get to work with. The wonderful pediatricians from LaSalle Hospital as well. I'm really thankful I've got to meet them and I've learned from them too. If you wanted to read about any of these studies or those guidelines regarding the position statements, which are available online in full, you could take a look at these references. And thank you very much.
Thank you for having us. It's nice to see some familiar faces, and thanks for inviting us to present. So I'm Elizabeth.
I'm Jessica.
We both used to work at Douglas here at PEP, and now we're both at Aire Ouverte. So we wanted to speak a little bit about Aire Ouverte. I think many of you probably already know what it is. Actually, I'm curious, does anybody want to share what they know about Aire Ouverte?
Or maybe who has no idea what Aire Ouverte is or doesn't feel super like.
Okay, a few people. And who has heard about it before? Okay, so most people already know what it's for. Okay, well, that's okay. Might be a little repetitive, but we'll still. Okay, so basically, we're just going to talk about what our mandate is and our target clientele, our service offer, our team, the different service points that we have, the research collaborations that we have at the moment, and then how to get in touch with us. So basically, Aire Ouverte is part of the global movement to offer integrated youth services to teens and young adults 12 to 25 and their families. So it's the Quebec version of that kind of initiative. So you might have heard of the youth wellness hubs in Ontario or Foundry in BC, or originally it started with Headspace in Australia, and there's versions all over the world and in all the different provinces and territories in Canada. The Aire Ouverte, the Quebec version, Aire Ouverte, is a little bit different because instead of being all services under one roof, it's more to create like a network of services because of the COC and the other services that are already in place. It made more sense to kind of work with all the existing youth services. It was launched the first sites opened in 2018, and then it was a gradual rollout.
And now every part of Quebec, every CEUS and CIS in Quebec either has an Aire Ouverte site already, or a couple of sites like we do, and or they're in development. So the idea is that it's accessible to all youth in Quebec. And our launch was in 2022. So we opened in 2022, but the implementation phase started earlier in 2021, at the beginning of 2021, because the idea was that part of our mandate is to include all different stakeholders, youth and families and other teams. And so we had a long consultation process before we launched the services in 2022. So the idea really is to improve accessibility. And in Quebec, we offer short-term intervention so as to not duplicate what's already offered in other programs. And the idea is, like I said, is really based on co-construction, and the ministry, they say, c'est pour et avec les jeunes, so for and with youth. It's accessible to everyone in the sense that it's no wrong door philosophy, but we do put in specific efforts to reach what the ministry refers to as a more vulnerable clientele, which is kind of up for debate. What is the definition of vulnerability? But essentially, it's youth who are having difficulty accessing services elsewhere, who maybe had a bad experience in the past, who are not sure where to go sometimes, who maybe have a little bit more of an atypical trajectory, who might have been lost when they finished, let's say, a follow-up in pediatric services at 18, and then a referral was sent, but they never kind of started the adult services. So vulnerability in different ways. And basically it's for any unmet health need. So physical health, mental health, sexual health.
Perfect. So I think what's super important to keep in mind is that Aire Ouverte is a service that's for any kind of health need, psychosocial need that youth might be going through, right? So we can think about, like what Elizabeth mentioned, mental health, addictions, physical health, sexual health, whether it's like employabilité, school, social life. But I think it's very important that we're not duplicating services that are already offered either in the community with community organizations or in the CEUS, for example. So I think kind of the key thing with Aire Ouverte is that we're very flexible, right? Like we are open in evenings. We kind of have drop-in periods where you can come and see us without an appointment. We are very present in the community as well. So if there's a youth that doesn't feel super comfortable coming to us, we will go to them. So we try to be as like flexible and easy to access as possible. We have no waiting lists, and I think that's like very key to why we try to keep our services short term is we can't afford to have a wait list, right? Like youth need to be able to access us when they need it in the moment. And there's no referral needed. So it happens, I don't know what the stats are right now, but we have a lot of youth that come to see us because, I don't know, they've heard about us through friends, they've seen our website, but we do have a lot of, let's say, parents, loved ones, or even like professionals in the community, in schools that are calling us to like refer youth to us. So it's kind of like open. Sometimes it's like, it can get confusing, but basically there's like no right way to access Aire Ouverte. You know, you can call us, they can email us, they can text us. We have a form. We're now available on Click Santé. So we kind of try to make it as easy to access in whatever way youth are comfortable to access our services. Like Elizabeth said, we have a no wrong door approach, which means that if a youth comes to see us, even if they don't necessarily fit these like vulnerability criteria, we're always going to welcome them. You know, like any youth can come and see us for any need. And I think what's also interesting about the no wrong door is, you know, the definition of what is a youth, I think, is also up for debate. So if ever we do have someone, let's say that's like 26 or 27 that comes to our sans rendezvous, we will still, you know, welcome them, try to hear out what's going on, and, you know, refer them towards the right services in the community or in the CEUS. We're not just going to like send someone on their way, even if they don't fit our age group. I talked a little bit about technology, but we try to be as easy to access with our technology. We also offer meetings on Teams for youth that might not be super comfortable meeting with someone in person. It does happen that sometimes we have youth that call in and they're like, I just want to speak to someone on the phone. No problem. Let's start off with that. Youth can be accompanied by a person of their choice. So if they want to come with a friend, I've had youth come with like boyfriend, girlfriend, partner, best friend, mom, dad, sister, so they can come with whoever they want. And I think what's also key is RAM-Q is not necessary for youth to access Aire Ouverte. So we have a lot of youth that prefer to stay not a lot, but we do have a few that want to stay anonymous. So they can actually come in, they can give us like a fake name or no name at all. They don't even have to have a RAMQ and they can still get help. Obviously, there's some barriers down the line if like they need to see a doctor or something, but like it does facilitate kind of building like a trusting relationship with youth that might be a little bit more méfiant or ambivalent. We're not sectorized, so obviously youth can come from anywhere in Montreal or Quebec. I think we see this a lot with, let's say, youth that are from maybe like Vaudreuil, for example, but that are studying at John Abbott and they might need some help and it's easier for them because they're in the West Island when they're in school, so they can come and see us, no problem. I talked about the anonymity. We have translators available as part of the CEOS services. And I think another key part of a lot of the work that our team does is we do a lot of outreach, right? So we have this model where we're not waiting for youth to come to us. We want to try to find the youth that might not feel comfortable getting services. So we do workshops with our community partners in schools. We do a lot of kiosks, foires with other organismes where we try to like get the word out about what Aire Ouverte is. So that way we're trying to be present in the community so youth know about us. And we have a very like inclusive governance. So basically we have a new youth council that we've started recently. And we're trying to also work with a lot of our partners in the community and in the CEOS to try to make sure that we're kind of like answering this need to reach vulnerable youth. I think for the service offer, specifically for our Aire Ouverte, so we have drop-in periods every single day. So youth can come in Monday to Friday. Some days it's during the day, some days it's more during the evenings. We're also open on Saturdays if youth want to call in. Youth can also make an appointment to speak with us on Teams on Saturdays. Historically, we've tried to be open in person on Saturdays, but youth don't want to come in on Saturdays. I think it's their day off, so we usually get calls. Actually, I think it's mostly calls from family members a lot of the times on Saturdays because they're off of work, and I think it's like a good time for them. Yeah, so I think I spoke a little bit about that. They can also call if ever they want. And a lot of the outreach that we're doing, the prevention and health promotion that we're doing is through a lot of our workshops and kiosks. So we have like a huge variety of workshops that we've developed with partners and that we're able to also co-animate with our partners in the community, whether it's on disinformation, sexual health needs, contraception, STBBI screenings. We have some about anxiety, healthy relationships, violence in relationships. So it's super, super varied. And we try to offer this as like kind of like a double objective, right? So not only are we doing like promotion and prevention about health, but we're also kind of putting a face on who is Aire Ouverte. So it happens very frequently that while we're giving workshops, youth will come and see us during the break or after workshops to be like, hey, you know, I have a bit of anxiety these days. I think I'd like to speak to someone. So it's like a great way to get youth that might not feel super comfortable to come meet with us. And I think too, a great part of our service offer is I think a lot of youth come to see us through mental health, but then when we, you know, let them know that we also have sexual health services, they're like, oh, well, I'd love to speak to a nurse about, for example, I don't know, like contraception or STDBI screenings or Plan B or pregnancy tests or whatever. So I think it's a good way to kind of have this like holistic view of health. So that way we're answering a lot of different health needs that youth might have. Good.
So in terms of our team, just to give you an idea of who's kind of professionals are on the team, this was again developed with youth and families at the beginning. They kind of told us who they thought what the gaps were and what they thought would be helpful for our sector. And I put the names because some of you might know some of them. So our manager is Tao, who's also the manager of the Établissement program here at the Douglas. We have an assistant head nurse who's our project manager. She's on mat leave, so Jessica is replacing her for Dorval and LaSalle. And then we have Andrew, who's replacing her for the West Island. And he's also used to be an IPS, like employment education counselor. There's also, we have 3 human relations agents. So one of them has a background in criminology and sociology. One of them is a spiritual care counselor. And then another one is a psychologist, but she's not part of the orders. She can't have the title of psychologist. We have another psychologist as well, who's a psychologist clinician. We have 3 nurse clinicians, and recently, well, actually in the last month or so, we've started integrating nurse practitioners. So we have 2 in the West Island and 1 in LaSalle. They're première ligne, first line nurse practitioners. So they work in collaboration with, we have 2 doctors as well that are on our sites. And so they'll mostly see youth for, the doctors mostly see youth for mental health needs. And so what they'll do is they will initiate the treatment plan and give the diagnosis. And then the IPSs now will be able to do the follow-up on that. So it allows us to see more youth in the doctor. That frees up a little bit of time for the doctors. We also have 2 peer support workers. So 2 youth, well, yeah, I guess pretty young.
Yeah,
who have
whatever your
lived-
definition of youth is.
who have lived experience with their own mental health challenges and who are able to overcome that and kind of create hope and share their story with the youth. And so they work in collaboration with the other workers. We have a social worker and we have Portage, a community organization for addictions that are at our Kirkland site every 2 weeks for a drop-in. That could get anybody?
No, I think that's it. So right now we have 2 like official service points. So the first one that opened in June of, I think, 2022 is our point in LaSalle. So I think what's super important to keep in mind with Aire Ouverte is we're part of the CES, but we're trying to also be detached from the CES in a way, because we know that some youth, it can be like intimidating for them to go towards these institutions. I think they kind of, you know, it's good to have like I don't know, how can I say this? Like we're professional, we're part of the CES, but also we're like our own thing where like we're trying to work with youth that are a bit ambivalent, right? So part of that model was being closer to community organizations. So our site in LaSalle is right on top of Destination Travail, which is the Carrefour Jeunesse Emploi in LaSalle. So it's a community organization that helps youth with finding a job, going back to school, volunteering. And it's actually a great partnership because a lot of the people that work at Destination Travail will like refer vulnerable youth to us once they start. And we will also refer youth to Destination Travail when they need it. And our second site that opened in September of 2023 is our Kirkland site, which is in the same building as the Santé Mentale Jeunesse team. So that's also great because it's easy communication between both of our teams. And I think a lot of the referrals that we make for youth that are having mental health struggles, it's towards Santé Mentale Jeunesse. So I think it facilitates that. For those that know where the old soccer store was on Saint Charles, that's where it is. That's where our site is. Both sites, as you'll see here, we're kind of like co-constructed, designed with youth. So our youth council, for example, in LaSalle, maybe you can give a bit more input about that, really helped choose like the colors, the furniture, the setup, and how the rooms were. And I think what's really positive is every time, well, not every time, but a lot of the times when youth come to visit us, they're like, it's so cozy here. It doesn't feel like I'm going to like a hospital. It doesn't feel, and I think it invites youth to feel more comfortable and to build a trusting relationship with them. Do you have anything to add about the site or?
I think maybe just that some of you may know that we used to have satellite sites as well. So we had an office in the Carrefour Jeunesse Emploi de la Chine and Carrefour Jeunesse Emploi West de Ville and the YMCA in Pointe-Claire up until April 1st this year. But with all the changes with Santé Québec and everything, we weren't able to maintain our drop-in there, but we still go there regularly. Like they have a youth that they want us to meet. Like for example, last week, they asked us to go and Jess and another worker went to go with them like pretty quickly. We tried to still be there for those youth. And also I had another point. Oh yes, for those that don't know, the youth mental health building on St. Charles is not in the CLSC, so it's still like in a community location. So the youth that maybe don't want to go to the CLSC, you know, it's the idea is really to be in the idea, as Jessica mentioned. In terms of our research collaboration, so these are the projects that we're collaborating with at the moment. Some of the youth from our youth council, what happened with the Center of Excellence is that when the Center of Excellence was created, we kind of merged both councils. And so some of the youth from our original council are actually still on the Center of Excellence youth councils. And so we're able to consult them from time to time. And now recently we have decided, as Jessica mentioned, to relaunch a council just for Aire Ouverte because we realized that we need to consult them quite often if we really want to be true to our model. And we have a lot of youth on the new council that actually almost all of them have received services at Aire Ouverte, and so they're really able to give us feedback concretely about what their experience was and what we can improve. The Aire Ouverte on a provincial level with Vidya and some other researchers, there's several research projects that are ongoing in terms of how to evaluate Aire Ouverte services and how to improve them. So we're participating in those as well. We have a project at the moment with a lawyer, and it's called Juriste Mobile. So she approached us because she wanted to offer services directly to youth in different Aire Ouverte sites. So we have an option for youth to meet with her at both of our sites, as well as Aire Ouverte downtown. They also are working with her. And the idea is to, again, make services more accessible so that youth don't have to go to a separate location to have consultations with her. So she offers basically on all kinds of different topics. If ever youth could benefit from speaking with her, she's available to them. We're also participating in a project called Adaptation culturelle des services jeunesse et Aire Ouverte. So basically it's similar to Aire Ouverte. It's kind of a co-construction model where there are youth, family members, and workers from different regions in Quebec. So it's a series of, I forget how many workshops, but I've been going since October. So it's been many months. And the idea is basically to figure out how do we reach youth from different cultural backgrounds and immigrant backgrounds, because we know that we have a lot of work to do in that area. And so we're coming up basically all together with a solution, and we have a meeting coming up in March where we're going to present that to they invited a few members of parliament and some people from the government and CEUS's like upper managers to basically present our findings and to see what is actually feasible to implement. Also, I was asked to participate in Walk the Talk, which our first meeting was yesterday. It's a program at CLSC Pierre Fond to figure out how to like create a service innovation. And again, there's different stakeholders around the table to try and, so it's not really related to Aire Ouverte, but it's a research project. And then there's other research projects that we regularly approached about that are existing that we share with our youth if they're looking to recruit youth, or with family members or other service users. And then I wanted to mention that Aire Ouverte is connected to Access Open Minds, as many of you know, in the sense that Access was a 5-year research project that kind of, I wouldn't say it evolved into Aire Ouverte because it was a separate, I mean, Aire Ouverte was financed by the government, and it was a separate envelope and everything, but we did learn a lot from Access, and a lot of the same people were involved in the implementation of Aire Ouverte who worked with Access, so we learned from them, and we continue to learn from the findings. And that's it. Basically, if you'd like to contact us, those are all the ways.
Hi, everyone. My name's Allison. I'm a psychologist, researcher, health systems person, do a bunch of different things here at the Douglas and in the youth mental health portfolio, but mainly working on the clinic for at-risk youth, so CAYR, and sort of bridging a new way to think about early intervention in terms of transdiagnostic staging science and what that means for actual service development and transformation. So just to ground us, what is early intervention, or what is the rationale for early intervention, right? The idea is that if we intervene in the early stages of a disorder, that we have a higher likelihood of improving the trajectory of recovery, reducing disability, mitigating the severity over the lifespan, right? So it's pretty logical. And in mental health specifically, early intervention means that we're talking about youth mental health, given that most mental health problems start in youth, right? If this was breast cancer, early intervention is with like 40 and 50-year-old women, for instance, right? But in our case, this is when the onset is happening. So if we take schizophrenia as an example of one of these sort of endpoint disorders that is quite disabling and quite costly to society in terms of, you know, the impact that it can have, as an example to sort of think about this early intervention model and what works and what might need to be rethought through a different lens. So for those who don't know, psychotic disorders, you know, can be really distressing and potentially disabling. They positive symptoms, as we call them, include delusions, hallucinations, disorganized behavior. There's often cognitive impairment and a host of negative symptoms, which include things like, you know, really significant social withdrawal and difficulty, you know, interacting and being in the world. So in Canada, having schizophrenia involves a 2.8 times higher mortality rate. It can shorten your lifespan 10 to 15 years, and it's an annual $10 billion cost to society in Canada to the impact of schizophrenia. And so obviously there's a clear incentive for us to intervene early, and this is a field that's done a lot of work on early intervention. So in the classic thing goes, okay, we have this end disorder that we want to sort of prevent or mitigate the impact of. And so what do? We look at the first sign of it, which, you know, is the first episode of psychosis, right? The first time someone experiences that sort of break with reality and those intense positive symptoms. You know, and it is a noticeable kind of point of development in the illness, right? It's usually people are really not behaving as they typically would, and their loved ones will notice a lot of the time. So, like, great, first episode psychosis, this is where we need to focus early intervention. But once, you know, we start doing that early intervention work in first episode psychosis, retrospective kind of studies and interviews show that, oh, actually, before even the first episode of psychosis, there's this prodrome, there's this period of declining mental well-being leading up to the first episode, right? Oops. So then we start talking about ultra high risk or clinical high risk for psychosis, right? And so this is sort of our clinical thinking model about early intervention, right? We went from schizophrenia to the first episode, and then to sort of identifying these symptom profiles of high risk psychosis. So often we're talking about subthreshold psychotic symptoms, you know, intermittent hallucinations or delusions, things that aren't quite to the level of psychosis, but they're starting to be distressing and we're starting to notice them. It all makes lots of sense. But then when we're designing services, what happens? So we say, great, well, we'll design a clinic that's for these clinical high risk young people, and we'll identify these cases, then we'll offer them some services and monitoring. And, you know, and then if they develop psychosis, great, we have PEP, we have our first episode psychosis program, and then we have our tertiary care clinic LETAP. And actually last year when I was on internship here, I had the opportunity to, as a psychologist, to treat patients from all these levels of care. I had a caseload that involved some of each, which was super interesting to see, you know, the progression of the illness and the early stages versus someone who's in their 60s with schizophrenia. You can really understand sort of the logic of this. And today I'm going to be talking about sort of here are the CAYR program specifically, right? So this program was founded in 2005. It's sort of a sub program with PEP, first episode psychosis program, mainly for subthreshold or attenuated psychotic symptoms without having had a full episode in the past. My formatting got a little messed up here, but oh well. And the model of CAYR is primarily sort of a psychiatric evaluation to assess, like, okay, what is the level of these psychotic symptoms? Sometimes it turns out it is a psychotic episode and then they can be seen in PEP. Sometimes it's like, well, it's not quite there. We'll keep an eye on it. We'll monitor it. There's some case management. Edits here does the case management for the cases where things get a little bit more complicated. Some medication, again, is needed. Sometimes a referral to psychotherapy, which is where I would see the patients, especially last year. But that's kind of the model. It's sort of like we're keeping an eye on these psychotic symptoms, see where this goes. So what's sort of the limits of this traditional kind of model of early intervention? That's very diagnosis specific, right? So first is that emerging mental health issues actually don't often fit into these diagnostic categories very clearly. So, you know, if I give you these symptoms, attenuated psychotic symptoms, mood lability, sleep disturbances, functional decline, all of these are shown to be, you know, present in clinical high-risk psychosis, and they're also shown to be completely present in clinical high-risk bipolar. So if we take a different endpoint disease like bipolar, and we do the same steps, you know, first episode mania, and then before that, the clinical high-risk state, it's looking a lot like the clinical high-risk state for psychosis. It's a lot of similarities. And so it's difficult to predict actually which mental illness someone may develop from a clinical high-risk state based on their early presentation. You know, locally here at CAYR, from what we published on, you know, there was about 11% that converted to psychosis. And you might say, well, you know, maybe we did a really good job at preventing the development of psychosis. And that may be true to some extent, but even in the literature, when they just sort of are following people necessarily intervening, it's about 20-25% that convert max to psychosis of the clinical high-risk psychosis state. But of those who don't transition, almost up to 80% will meet criteria for another mental health problem at some point. So it's not that this group is not actually at risk. They're actually at quite high risk for mental health problems. It just may not be psychosis. And we can't always know where these things are going. And that's part of what we call pluripotentiality, right? We know there's a level of risk. We know things aren't going well, but we are not always the best at knowing what is the endpoint or what direction is this going in the early stages. And of course, when we create a system that's so focused on these diagnosis-specific trajectories, we can create inequalities. We have a more fractured system. So we know that like access and wait times can then become highly variable, despite similar levels of need. You know, at PEP and CAYR, because schizophrenia and psychosis, the field has been so focused on early intervention, has developed these really excellent programs for early intervention. If you get flagged in that category, you can get seen quite quickly. But you know, if you're on the let's say the mood end of the spectrum, with, for instance, with bipolar, so we know that currently we don't have like a suite of early intervention services in bipolar, and it can be quite a long wait to be seen at CEYH. So, you know, if we accept that early symptoms cut across diagnostic boundaries, then our intervention model should be organized around stage and need, not sort of the endpoint diagnosis that we think that we're predicting. So this brings me to the transdiagnostic staging model, which Dr. Jay Shaw in the back there is one of the conceivers of, or one of the researchers working on it. So I've synthesized it a little bit. There is a stage 0, which is no symptoms, but a host of risk factors, let's say. Jay, you got something
I
to
didn't
add?
conceive of it, just to add. I study it.
You study it, you contribute to, you write consensus
I write
statements about it. Okay, sorry. Take the credit. So the logic of the transdiagnostic staging model is sort of this idea that, you know, mental health issues progress over time. It's kind of developmentally informed, right, as people get older, through youth. And so stage 1A is what we think of as maybe what's something that might be appropriate for like multi-multiple jeunesse teams. So often anxiodepressive symptoms, some sort of in the mild to moderate range. And it's not always sort of, again, clear. It's not a specific endpoint diagnosis, but there might be some sleep disturbances. There might be some anxiety, those kinds of things. Stage 1B is when we start to get to more complex, concerning, overlapping subthreshold symptoms. So there might be some psychotic elements showing up. The mood lability is more significant. We're seeing bigger breakdowns in functioning. But importantly, we still don't sort of know for certain what this necessarily is. Stage 2 is when we talk about that first episode, right? So for psychotic disorders, it might be the first episode of psychosis. In bipolar disorder, we often talk about mania. And for other, and here I put serious mental illness, which can be a whole other discussion of what that exactly refers to. But, you know, having worked in eating disorders, I think we can think of some severe presentations of eating disorders, for instance. There are other serious mental illnesses where you might have sort of a point at which you go, okay, we think this is the first big sign of something happening to do with this disorder. But you'll note I still overlapped those little bubbles because, you know, those who have worked at PEP know, you know, sometimes someone has a psychotic episode, but is it actually a manic episode? And, you know, a number of PEP cases, if it move on to CEYH eventually, because it's actually bipolar. So even at stage 2, there can be some overlap in terms of diagnosis. And we know that there are, you know, like affective elements to psychosis. And I want to emphasize that there's overlap even when we start moving on a little bit farther. So it's important to keep this transdiagnostic lens, even as things become a bit more clear over the trajectory of the illness. So how do we sort of try and integrate this kind of a transdiagnostic model into our, you know, current services, which can be quite, you know, siloed and diagnosis specific. So, and we'll be talking about CAYR, which is the stage 1B, the clinical high risk. So the vision at CAYR is to sort of have this model implemented so that we're seeing stage 1B or clinical high risk youth beyond just psychosis, right? Because we think that probably if we, we're not necessarily doing things very usefully if we're only focusing on the psychotic elements, that there's more to the picture here. So the first step we're taking is to expand eligibility to include clinical hires for bipolar disorder presentations. And part of that is because the prodrome of psychosis and mania overlap substantially, and there's been a lot of research about this in the literature. Additionally, there are not many early intervention bipolar services at the moment, so this sort of fills a systems gap and addresses a need that's likely there within our CEUs. And in parallel, and this is not the focus of this presentation, but it's coming. There's we're working towards a first episode mania program as well, right? So this fits with expanding the early intervention portfolio and thinking about how can we intervene early across sort of serious mental illnesses. Obviously the hope for the future and long term is to maybe even move beyond just psychosis and bipolar, but this is sort of a practical first step. And given the amount of overlap, it's a logical one. It makes a lot of sense in our context as well with other projects that are ongoing. So not only are we sort of moving towards expanding the criteria, but it's also about rethinking the model of care, right? Currently, we're sort of in this psychiatric monitoring of psychotic symptoms as the sort of modus operandi. What we'd like to move towards, and we're already starting to do some of that, is prioritizing early psychosocial interventions, right? So part of this is because we know that 60% of the clinical higher psychosis patients report significant mood and anxiety symptoms, right? We know there's suicidality, we know there's self-harm and substance use and issues with social and occupational functioning, right? And if we're just focused on monitoring psychotic symptoms, we might not be doing everything we can to address all these other mental health problems that are in the picture. So for instance, we want to make, and this is me as a psychologist, this has been my influence, make group therapy a core treatment pillar. I just developed a new group that's sort of a bit of a mental health 101. Transdiagnostic addresses a lot of sort of the common mental health issues that cut across many disorders. So, elements of cognitive behavioral therapy and DBT, some third wave elements, but really distress tolerance, anxiety and avoidance, just understanding their mental health, emotions, thoughts, behaviors, and also getting them in a room together with other young people. So there's that peer support element and normalizing their experience and feeling less alone. So that's something that our group therapy program that Alex and I are running just started last week, but has so far seemed positive. And we'll be sort of evaluating it after the fact and seeing how we can improve it and iterate on it. We're also working to make case management with a really active community component a bigger part of the services, hopefully eventually with most of the clients or patients having access to case management. Alexandre again is sort of the lead on this and does excellent work already, doing a lot of community visits with our patients. We're working to implement measurement-based care. There's the Take Care platform that's sort of being implemented at PEP and will be implemented at CAYR as well. And we continue to have psychiatry, readily available as needed because we are still monitoring those concerning psychotic symptoms and manic symptoms in the future. And so we're not getting rid of the psychiatry element, but we're just trying to build out a more holistic mental health program for youth who are clearly at risk, if not of necessarily psychosis in every case. So that's really the direction we're going, and we've been doing a lot of work on this year. So in conclusion, we know that early mental illness, early stages are sort of transdiagnostic, and there's a fluidity there. We know that if we stay too much in our diagnosis-bound early intervention, we create silos and delays and inequities, and that taking a stage-based approach helps us align the care with the clinical needs. So that's really the vision for this transformation at CAYR.